Okay. Hi, everybody. Welcome. We've got a fair number of people joining remotely, and we've got a lot of you guys in this room. Thank you so much. It's because this is an important topic and a well-versed speaker who most of you guys in this room know well.
I'm going to listen to it through mine.
Today, Dr. Fred Rottnek, MD, MA, HCM, Professor and Director of Community Medicine here at St. Louis University School of Medicine and Medical Director of the Physician Assistant Program, is going to talk to us about the state targeted opioid response, what Missouri is doing and why. He's a graduate of St. Louis University School of Medicine here, and he has a Master of Arts in Healthcare Mission. The program was at Aquinas Institute of Theology. On September 30th, 2016, he completed 15 years in correctional healthcare at the St. Louis County Department of Public Health at the Buzz Westfall Justice Center and St. Louis Family Courts. He teaches in the School of Medicine, the PA program, and the Interprofessional Education program. Dr. Rottnek serves on the boards of the St. Louis Regional Health Commission, the St. Louis Criminal Justice Ministry, and the Alive and Well Communities. Recently, he joined the Assisted Recovery Centers of America as medical director, and he's part of the clinical training team for the Missouri Opioid State Targeted Response. He's board certified in family medicine and addiction medicine, and is developing a SLU fellowship in addiction medicine. Welcome, Dr. Rottnek.
Today, earlier, if I fall into a sweaty mess, it's because both right in this room. You're in my chair. Yes, that's where I sat. Okay. Today we're going to talk about, as Nicole mentioned, the state targeted response. What is it and what are we doing in Missouri? But before we get started there, show of hands, and you folks remotely can play along too. Okay. Think back to when you were 4 or 5 years old and Grandma Hilda or Aunt Betty said, yeah, honey, what do you want to be when you grow up? Okay. Have you got your head back there? All right. Raise your hand if you said, I want to be an alcoholic, or I want to be in prison, or I want to suffer from a serious mental illness. Okay. Folks remotely, you probably don't have many hands up either. The reason that I say that whenever we talk about addiction and substance use is because these are not aspirational states for the human, right? We do not aspire to these conditions. So all of us here in this room who are engaged in healthcare professional training or healthcare professionals, our role is to help people who find themselves in these situations in life. It should not be any different from someone with diabetes, hypertension, asthma. So let's start off with that and we'll come back to that. Okay, let's see here. All right, stuff I do, Nicole already said that. All right, good. All right, what we're going to talk about today, we're going to discuss the impact of the current opioid epidemic at a national, state, and local level. Talk a little bit about the elements of the state targeted response here in Missouri. We'll talk about the meds used to treat OUD and what you as students can do to make a difference right now. Too often we talk about, oh, you'll be able to do this in 4 years. It's like, what can I do in the meantime? Study? Okay, but we'll talk about things you can do right now. And of course, we're not going into depth over all this over pizza today, but these are things that I will give you lots of references at the end, and I think Nicole has already sent out the slides. If not, she will for everybody who signed up. Okay. What's different now? Why are we concerned now about opioids being an epidemic or being a public health crisis? We've never talked about addiction as being a public health crisis. And I always like to say this right off the bat, and some of you have already heard me say it this year. Opioids and addiction became a public health crisis when rich white kids in the suburbs started dying. Okay. We lost a whole generation of young people, mostly young Black men, who died in the urban core in previous epidemics, such as meth, crack, and things like that. Okay. Once legislators' kids started dying, bankers' kids started dying, attorneys' kids started dying, all of a sudden it became a public health issue. hard to realize that or hard to accept that, but it's true. But the door's open now. So let's stick our foot in it and let's see where we can go. But it's very important for us to own our history when we talk about how we respond to an addiction. Okay, look, there's a few other things on this slide. Meds are cheaper, okay? They're purer and stronger. Those of you guys who watch Breaking Bad, I could only get through one season. It was too much like work for me when I was still in jail, okay? There's a lot of series I missed because of that. You know, Orange is the New Black, a few other things. But a lot of people now are able to make these meds at home. When I was where you guys are in training, the only time we heard of fentanyl was in the OR. Okay? But now people can make these things at home. And they're easy to get. When I talk to parents, and parents say to me, my kids don't go into bad neighborhoods to buy drugs. Where are they getting them? I said, where do your kids get their dates? Euphemism, right? Nobody knows what I meant by that. You're on a good Jesuit Catholic school. Okay, but the point is that you can meet somebody in the Schnucks parking lot and get your dope. Okay, in the old days, maybe you had to drive to the city or drive to a bad neighborhood. Or as I found out recently, the Roberts building where the HRC is, I found out from a buddy of mine who's a recovering opioid addict that that's where he bought his dope. He told me one day, it's like, oh, circle of life. Okay. The other thing is that opioids are deadlier, and we'll talk about that in a minute. One of my very favorite slides in all the world here from that evidence-based resource known as Facebook, but I did verify it, it's true. This slide shows you why people are dying today. Because if you look milligram for milligram at just these four we have here, you see why prescription morphine, heroin now is twice as strong, milligram for milligram. Fentanyl, 100 times as strong. Carfentanil, literally an elephant tranquilizer. That's where it comes from, is veterinary care. 10,000 times stronger than morphine, okay? A milligram would kill everybody in this room. Okay? This is what's on the market now. This is what's in neighborhoods now. Every overdose death in St. Louis County last year from opioids was fentanyl-laced heroin, okay? The next thing on the scene is going to be fentanyl-laced cocaine. Back in the day, in the 50s and the 60s, when heroin was a big deal, a lot of my favorite jazz singers died from heroin overdoses. Billie Holiday, Dinah Washington, a few other folks. Heroin was a consistent strength, so people kind of knew what they were working with. Now, not only is heroin itself about 5 times stronger than it used to be, but then now there's other additives, and then people are making these other things in their basements and labs. A lot of this is coming in from China right now. But the unpredictability of the strength is what's causing a lot of these deaths, and people can die from one use. That's why we're very concerned about this, and we're trying to get the word out. Also, while we're on it, though, we're not talking about pot today. Your pot today is not your parents' pot, okay? Pot today is about 5 to 6 times stronger than pot used to be. So those are other things, but that's a whole nother discussion. All right. Many of you have seen this slide. This goes to 2016 from about 1990. Take a look if you can see what these different lines are. At the height of the AIDS epidemic in the mid-90s, you can see how many people died from HIV/AIDS, okay? Not only have we passed that, we've passed car accidents, we've passed gun deaths, and right now we're well above HIV. Something that should be in here is Hep C. More people die from Hep C every year than they do from HIV, and that's been since 2008. Okay? What's important now is the numbers just came out last week that over 72,000 people died last year from drug overdoses in the US. So if from 2016 to 2018, add 20,000 onto that, that we know of, okay? Other way. Now, this gives you an idea of what substances are we looking at and why. And don't worry, today won't be all Debbie Downer. We'll have some bright spots. So you'll all walk away going, oh, I hate my life. When am I going to be a healthcare professional? Take a look at these. The top three: fentanyl, heroin, prescription opioids. The top 3 reasons people die from drug overdoses are from opioids. That hasn't changed. The next one's cocaine, meth, and methadone. Methadone's coming down. It's the only one that is. not to freak out people too much, but think back to calculus. You can use calculus, okay? Slopes. It's bad enough that this many people died in 2016. Look at these slopes. These are scary. Not only for opioids, but look at the slopes with cocaine and meth. One bright spot, though, when we look at this, is what some of the work we're talking about today with the state targeted response. If anybody saw it on the news this week, Missouri deaths increased 10% from opioid overdoses last year. In St. Louis City, they dropped 10%. Why did they drop 10%? I think a lot of it is the work we're doing in the state targeted response, because otherwise there'd be no reason to think it would drop 10%. But that is a big deal, and we'll talk about why as we move forward today. And if anybody has a question, holler. You can, I'm not the most formal with people, so just holler. Okay. Now, where in Missouri, if we look at a broader scale, where are people dying from opioid overdoses? Right here. Anybody from Kansas City? Okay. What's the big drug there? Meth. Good for you. But he's got good teeth. It's okay. I can laugh about anything he said. Okay. Take a look at the Eastern District and look at the preponderance of opioid deaths on the eastern side. You'll see a line that kind of goes down the country that you can see where people are dying from what. The western side of the state, including the whole southwest region, still a lot of meth-related deaths. Opioids, unfortunately, are catching up. But we're at the crossroads here in St. Louis and Missouri, like we are with many things associated with public health and community safety, because of the way the highways run, right? North-south, Highway 55, east-west, 64, 40, 44, right? That's why in St. Louis, we have a higher than predicted amount of STIs, of human trafficking, of drug use, of all that, because where the highways are. It used to be where the railroads were, so St. Louis was big then, and before that, it's where the rivers were, okay? So there's trends and patterns, so that's why we see this in St. Louis a lot. And for those of you who from the south, southern region, we're seeing a huge proportion of people dying in the counties south of St. Louis County. There's a lot of, you can just follow Highway 55 south. And those are also very economically depressed regions. Okay. So what is the state targeted response thing we're talking about? One of the last acts of the Congress under President Obama that was passed was the 21st Century Cures Act in December of 2016. What that was an attempt to kind of reimagine and restructure how funding comes out for mental health care and addiction care. One little part of that budget was $1 billion that was to be spent for addiction, and that's called the state targeted response, where every one of the 50 states were allocated a certain amount of money based on demographics and overdose deaths. With that combination, overdose deaths over demographics, what states do you think got the highest amount of money? If any of you are keeping up on this stuff. Yeah. Virginia, Kentucky, West Virginia, those areas have really been hard. Okay? Also, those are the areas where there's been a lot of coal mining, where the economy fell apart, and a lot of other labor industries where you just see large depressed communities. Okay? If you look at SAMHSA Region 7, and SAMHSA is the Substance Abuse and Mental Health Service Administration, Region 7 is Missouri, Iowa, Nebraska, and Kansas. We by far have the biggest chunk of change here in Missouri because of the number of opioid deaths and the amount of our population. So anyway, $1 billion spread out over 50 states. Has anybody here?
Let's see how I can mute it.
Has anybody here been to Las Vegas? Anybody been to Wynn? That one? Does anybody know what that cost to build that complex? $2 billion. We're talking $1 billion. Okay, just to give, not that $1 billion isn't bad. I'll take it. But at the height of the HIV epidemic, $17 billion went to U.S. funding for HIV research. And if you don't know yet in your training, you will learn the incredible things we've learned from the investment in research related to HIV, what we know about viruses, immunity, immunology, a lot of things. So anyway, Missouri was eligible for $20 million. And what we had to do as a state was figure out how do we want to spend that. 4 big buckets. And I wasn't a big part of the planner here, kind of almost like a month before it was due. The program director, who they work out of Missouri Institute for Mental Health, which is located up in UMSL. They called me up because I talked with them on other things, and they go, "Oh, we realized we might need a primary care doctor on this." I go, "Do you?" So I said, "Sure, let's play." Here are our 4 big buckets: prevention, treatment, recovery, and sustainability and community impact. Now you might think, ooh, 20 million over 2 years, cool, we're gonna get this thing fixed. Any of you who have worked on grants, or any of you who have had a big influx of cash over a short period of time, which I don't think is most of you, you realize it's hard to spend money responsibly that quickly. That's part of the reason we're here today, because what's one of the best ways to do that? Workforce development, okay? But one of the other ways to do it is to really track outcomes of pilot projects. One of the great things that MIMH has done is that they set aside money in the budget to really track the outcomes of the different pilot projects we're doing in the state targeted response. Why? So we can inform our legislators, our policymakers, and other decision makers on how best to spend money, how to do reimbursement for insurance, how to shake things up so we're doing the right stuff with limited resources. Does that make sense? So we can get great outcomes. The next thing is we have to convince our legislators. I don't know if I'm going to sign on to that, but we'll see. Okay, prevention, treatment, and recovery. Prevention efforts, school programming. Who went through a DARE program? Who knows the evidence-based outcomes of DARE programs? You started using drugs at an earlier age, didn't you? Okay. Either no impact or kids start using drugs at an earlier age. Because I saw it at school. Yet we still fund DARE programs, right? What does work with prevention with kids, especially? One, an asset-driven model to self-esteem. What are you good at? How do you build your skill set around that? How do you cultivate the people in your life that have similar values? The second one is what we call denormalization, which you probably feel you're going through right now. But denormalization is working with high-risk kids. And I would have been a high-risk kid because my mom was an alcoholic, dad is a binge drinker. And I would be a high-risk kid because of my exposure to that growing up. I would think that it's normal to come home from work and throw back a couple scotches when you have a bad day, or you have any day. I would think that'd be normal, right? The goal of denormalization training is to get the high-risk kids together and tell them it's not normal to do that. That is not what most people do. That works well as well, okay? Now, if teens have an addiction, what also works extremely well is family therapy. Because most teenagers are living at home, why would you expect to have a teenager try to sober up but then go back into the same system that probably promoted that behavior? I'll bunch of little pearls today for you. But these are things we're doing with prevention. We're doing what we're doing today, telehealth education, and we also do echo training so that folks, if they're experts in urban areas, but they need experts in rural areas, we can do training professional to professional. And we do a whole lot with overdose education and naloxone distribution. You guys have all heard of Narcan, right? That's the opioid reverser that we know first responders use to help reverse the effect of an overdose. We'll talk about that in a little bit. If any students here want to have somebody come in to do Narcan rescue training, I know all the people who come in and do it for free. Everybody who knows somebody who's on opioids with prescription or illegally, everybody should have access to Narcan. Because if you need Narcan, guess what? You can't give it to yourself, okay? Think about that. We'll talk about it a few questions later. All right. Other prevention efforts. Notice all the cute Mo names. Mo Heroes. It's like we need Monique to come in and be our spokesperson. Okay. This program works with the city jail and the county jail so that if folks are released from jail, our efforts like to stay at the jail. In the county is 40 days, in the city it's about 80 days. Most people don't go back home. If they haven't gotten treatment for their addiction inside, there are huge risks for overdose during the first 30 days they come back out. So in this program, people can leave jail with Narcan. Why? Dead people don't recover. That's another deep thought. If we can help people stay alive, no matter where they are in the stages of change to sobriety, if we don't help them stay alive during that time, we know they won't recover. So that's what we call harm reduction. We'll talk about that as well. The community program around naloxone is important because when our Director of Health and Senior Services in Missouri came in under the previous governor last year, it's been a busy year, Dr. Randall William wrote a standing order that anyone can go into any pharmacy and buy Narcan. But not every pharmacy knows that. So this group works, our partners at the College of Pharmacy work to do outreach so that every pharmacy in the state knows this. Okay. These are the three medications that we talk about the most. And if you want a mobile app for opioid use disorder, you can get a free one from Samsung right there, MATX. Go to your iTunes store or Google Play. I tell our clinical students in their third and fourth year to download this so that they can not only take care of their patients, but just while they're attending. All right. The three we're going to talk about here, we're talking about Narcan, naloxone. We're going to talk about MAT with methadone, buprenorphine, and naltrexone. What are these and how do they work? What do addiction medicines do? Okay. This is as complicated as the brain gets for a simple family doctor, but right here, brainstem, right? Drugs, sex, and rock and roll, all the primal things that keep us alive, right? I'm hungry, I need to breathe, I need to have a heart rate, I want sex, I want to reproduce. Well, I don't want to reproduce, but you know what I mean. All those urges are right there, okay? Or like what we like to call the lizard brain, right? The primordial brain, the basic brain. Now, you get up here to the prefrontal cortex, that's called the wizard brain, okay? That's where our executive functions are, the things that moderate what happens down here, right? It's like, ooh, I'd really love to go and stop and get a margarita after this lecture today. Oh, but wait, it's the middle of the day on Friday and I have some work to do. And I might get in trouble for that. I don't think I will. I'll wait till later, okay? That's what the prefrontal cortex does. It helps tamp down, among other things, some of the urges we have with our lizard brain. So wizard brain, lizard brain. What happens in addiction, as in with some of the other things with serious mental health, the communication between those two gets jacked up, okay? That gets jacked up. Think back to Maslow's hierarchy of needs. You've thought about that before, right? The bottom, biological, physiological needs, lizard brain stuff, right? The top of Maslow's hierarchy is self-actualization. And we're all self-actualized, right? Hopefully, someday. Those are executive functions. That's when you're practicing at the top of the game. You've hit all those other levels, getting you to the top. What happens in addiction is you flip that pyramid to where all you can think about are your basic survival skills. So if you say to somebody who's in active addiction, what you're doing makes no sense. Duh. It doesn't make any sense because all of us who aren't addicted are operating at a place above our biological needs. When people are operating out of lizard brain mode, they're looking at basic functioning. Where do I get my food? How do I keep these cravings under control? And if you say, why does drug use lead to crime? Because people will do anything to get their cravings under control, so they lie, cheat, and steal to get the meds they need. It just makes sense. We were talking earlier, we got to get out of this moral failing things where people with addictions are just bad, lazy. They brought it on themselves mentality, right? Think back to our question about Thanksgiving and Christmas when you were 4 or 5. There is science, people, facts to show that these things are connected. So not everybody needs meds. Our brains are different, but the difference really affects treatment outcome. What we're talking about today is what goes on between our nerve synapse and the synapse here, right? We've all heard about neurotransmitters and chemical messengers that keep an impulse going from one nerve to another. That's where this comes into play. All right. Let's talk neuroanatomy for a minute. We're not going to get that complicated. All you have to think about is Lego blocks. Okay. Y'all know what Lego blocks are. Okay. Even you youngsters. I know the older people nodded their heads. The little plastic things you put together. You've probably seen a game online that you could do on your phone with Lego blocks. Okay. So your nerves all have mu receptors. Think of the holes with Lego blocks, okay? Let's say our nerves normally have 2 mu receptors. Mu receptors are where opioids plug in to pass on a current and to release dopamine. Dopamine is a neurotransmitter that makes you feel warm and fuzzy, okay? When you're calm, when life is good, when your evil cat comes down and sits on your lap. Those warm feelings, okay? That's dopamine. Or you're better off and you just get a dog. Okay? That's dopamine. Those things that help us feel safe and secure. All right. When you have an opioid act on one of those receptors, what happens is that dopamines get released, all is good. Now let's think about if we got a lot of dopamine, if we got a lot of opioids in our system. We have mu receptors, but we've got all these extra opioids out here because we're using heroin, we're using perk, we're using whatever. Our nerves actually change in what we call upregulation. And I know some of you know about all this stuff, but that's cool. Upregulation. I might have had 2 receptors on this nerve before, now I have 5. And they all get plugged up with an opioid. We feel good, we're releasing dopamine, life is sweet. Guess what happens if you stop the opioids? You have all these receptors waiting in the breeze that aren't plugged up, and you don't feel good, okay? In time, your body downregulates. In other words, you'll go back to those 2 receptors. Does that make sense? Okay. The 3 meds we talk about, let me look at my next slide here for a minute so I remember where I'm going. Oh, okay. Let's talk about this slide first. Y-axis, algebra is important, people. Y-axis, dopamine levels, mood, whatever you want to think about. Y-axis, feeling good. Normal state, the green is a euphoric state or feeling high, but euphoria is polysyllabic, so it's more professional. And then withdrawal state. If you're in a withdrawal state from opioids, sweating, diarrhea, jittery, vomiting, all those things, right? Not a pleasant state to be in. So your y-axis here is your mood, your dopamine level. Your x-axis is time, acute use and chronic use. Assuming everyone in this room has an opioid naive brain, meaning that you're not on methadone, you're not taking Percocet, things like that. If we took a couple Percocet, we would go from normal to euphoric. Why? Because we're plugging up our mu receptors and releasing dopamine, right? If you get a lot of dopamine, you get a dopamine surge, you go into the good zone. What happens in time, though, is, and this is where it's frightening, if you have a biological vulnerability to addiction, and we know that we do that depending on our genes, we have evidence to show that within 7 to 10 days, your system can upregulate so that if you continue to use so you can stay in the light zone. Okay? If you've worked with somebody with addiction for a long time, and I've done that a lot through my work in corrections and homeless work, and I knew they used that day, and if I asked them, when's the last time you got high? They might say 3 years ago, 4 years ago. Why? Because they're using to get into this zone so they stay out of the withdrawal state. Does that make sense? Okay. If that really makes sense, it really changes how you look at addiction. Because what somebody's doing is responding to a biological need that has developed in their nervous system. And folks continue to use to feel normal. People don't go from here to here. Though I've not yet seen it in print, I think that's part of the reason why people use fentanyl. Part of the reason is that there's a hope that they can get up here. Do they? Probably 5 seconds before they go into respiratory depression. So this happens over time. Now, if we continue this graph, again, to the same state, y-axis, euphoria, dopamine, x-axis, time, How do we get somebody from bouncing up and down, from oscillating between the white and the red, to getting them into a smooth white state? That's where the magic happens. Okay? What happens in this trapezoid? And we throw a little geometry in there too. Okay. Only 10% of people in the US get medical assistance for addiction. A small number of those people don't need it. A large number of those people do, but the stigma prevents them from doing so, or the lack of access to care. Okay. But so a lot of people either quit on their own, have a lifetime use, or overdose and die. But this is where the medication piece can come in. So what do the medications do again? They help your system downregulate. They help you get your cravings under control. Because once you're able to get your cravings under control, and you're not, especially with opioids are one of the worst for cravings. Once you're not spending every moment of your life thinking about when did I get my next fix, then you can participate in therapy. That's the magic of medication first. Think about it. If you were obsessed with cravings, how would you be on cognitive behavioral therapy? Not going to happen. I mean, that might have been someone right there. But that's where the medication first piece comes in. Get the cravings under control, help the brain start to heal, and then you can do the hard work of changing behaviors. Yeah.
How long is the down-regulation? Years or is it months?
It's months to years. Yeah. And it depends on how much you're using, how many things you're using, and when you started using, right? Because if you think about it, again, it's kind of common sense once you think about it, but if you don't, you don't. Somebody who starts using at a very early age, 12, 13, 14, a lot of my kids at detention did. How old are we when our brain's fully developed? 25 to 27, right? If you start using psychoactive substances that jacks up your structure and chemistry at a really early age, like 10 years before you could expect your brain to mature, who knows if that brain is ever going to be quote unquote normal, okay? So those are the kind of things we kind of have to balance when we look at some of the medication. So that's a really good question. All right. So medication first, get things back to normal. Now let's go back to our other slide here. These are the 3 meds we use in addiction medicine for opioids. There's only 3. How many blood pressure meds are there? I don't know, 30, 40, and then we name them different things and combine them so we can extend patents and stuff and make more money. Whole nother talk. All right. These are the 3 meds we use most often in addiction. An antagonist. We know that if an antagonist attaches to a mu receptor, it blocks action, right? That's what an antagonist does. So it blocks, if you give somebody naltrexone, the 28-day injection version is called Vivitrol, what happens is that would block this dopamine receptor, mu receptor, and it would kick out any opioids. That's kind of what happens with Narcan. We'll mention that a little bit. But an antagonist blocks further action, right? So what happens with an antagonist, if that occupies these sites, I could get a shot of Vivitrol, I could take naltrexone today, I could then throw some Percocet down, I would not feel an opioid effect because the antagonist blocks dopamine release. Does that make sense? So if I took a small dose or a large dose of naloxone or naltrexone, there's not going to be an increase in dopamine or opioid effect, right? Because it's an antagonist. Now let's do the complete flip side. Again, scary graph, okay? Opioid effect, dopamine, you name it. So if we go over here to the y-axis, let's look at methadone. Methadone is a full-on opioid. It's a synthetic opioid. It's made in the lab. It goes way back to the 50s, 60s. But opioid, since it's a full-on opioid, the higher the dose, the greater the opioid effect, the greater the dopamine effect. People die from methadone overdoses because you go up high enough on any opioid. How do people die? Respiratory depression. They stop breathing. You can always tell the med students, respiratory depression. It's like, they stop breathing. I'm not, you know me. Okay, they stop breathing. I like simple language. All right. So why would you give somebody an opioid if they have an opioid addiction? You're plugging up the mu receptors again, right? And you're allowing the cravings to get under control through a monitored distribution of medication. In time, what you would want to do is, as the brain heals, you'd want to taper down that methadone dose, right? And get them off opioids. You're also keeping people off the street, going to their corner pharmacist to buy their heroin, but God knows what's in it. People might be using used needles, exposing themselves to Hep C, HIV, things like that. So yes, you are giving somebody an opioid, but you're giving them an opioid to get cravings under control so you can do the behavioral change you need to do with that person. Okay. Now, the med we use that falls in the middle here is buprenorphine. Buprenorphine, I'll call it bup. This is Suboxone and Subutex, are versions of this. Zubsolv, a few other things. It's called a partial agonist, and this is a little freaky, so if you don't know what this means, think about it in 2 years and you'll figure it out. Dose response. As you increase dose, you get an increased opioid effect. But the cool thing about bup is it has a ceiling effect. After a certain dose in every person, you get no more opioid effect. You kind of top out, which is why it's called a ceiling effect. What that means is that if somebody takes bup by itself, it's very difficult to overdose. Because unlike methadone, which will go way up infinitely, bup tops out with the ceiling effect. Okay? That's one of the reasons why we really talk a lot about bup and using it in primary care settings, because it's a safer drug overall than methadone. There's still a role for methadone, but bup is a safer drug. Okay.
Can people still overdose on it?
Bup? Yeah, especially if they take some benzos or some alcohol or something else with it, right? And that's what happens most frequently, is that if somebody's on bup, you really have to work with them to stop any other substances of abuse, especially those that are respiratory depressants. Yeah.
Is the ceiling effect ever too low where they don't get back to feeling normal?
Yes, and that is such a good question. Everybody hear that? Is the ceiling effect ever so low that people don't go back to feeling normal, that their cravings aren't controlled? Yes, in fact, that's exactly why some people still need methadone. Imagine most people's cravings are controlled probably somewhere around here, okay? You're still gonna have people, due to brain structure, brain chemistry, all those things, that their cravings aren't gonna be controlled until you get an opioid effect up here. That's why you might have to take somebody off of bup and have them on methadone. I'll buy you pizza. That's such a good question. Okay. Naltrexone, antagonist. Here's where you're gonna see it. There's an oral form and a depot form. There's a place for both, especially because the depot form is really expensive. The oral form you can take every day or every other day. It's an antagonist. And it works extremely well for alcoholism too. I could take naltrexone now, throw down a pint of whiskey. I won't feel drunk. I might have a hangover. I might not be able to walk straight because those are other receptors. Alcohol is a really sloppy drug. It hits immune receptors and it hits other receptors too. But it's really helpful for folks with alcoholism too. But since it's an antagonist, it doesn't do a whole lot with dopamine. It doesn't push out dopamine. Okay. Methadone, full-on opioid agonist. It works great, except, I blacked out something here. It has the biggest dopamine push, back to your question. The thing with methadone, though, the way it was started in the 70s, it's a highly controlled distribution system. You have to live near a methadone clinic because since it is potentially fatal, toxic, I should say, you start out the first 30 days, you have to go every day to get your daily dose. It's stigmatizing, and then there's a lot of rules about therapy and all that. Not that that part's bad, but it's really difficult unless you can get to an opioid clinic every day. Whereas with bup, this can be done in a primary care. Actually, anyone can do this with a medical license, an NP license, or a PA license, assuming you do all the training that goes with it. Congress, in all its wisdom, decided that the antidote for opioid use disorder, you need to do additional training for it, though you don't need to do additional training to prescribe Percocet. Okay. Probably the methadone lobby and the AMA are part of that. You didn't hear it from me. Okay. So this is where this comes along. It's usually a sublingual film under your tongue. It can be a tablet also that is under your tongue. It does have dopamine release, but back to it may not have enough for everybody. But due to its safety profile, if somebody needs an agonist, you want to start with bupe because of the safety issues. Okay. Now, when we talk about medication first, take a look at this slide and it gives you an idea of what we're talking about. Back in the day when, probably before most of you were born, and a drug came out called Prozac. That's when I first got treated for major depression, which I know you're probably thinking major depression. He seems a little wound up today. I had a lot of coffee. Back in the 80s, SSRIs came out, selective serotonin reuptake inhibitors, really changed treatment because of the safety profile of the meds. And what happened is that a lot of physicians, including primary care docs and family docs like myself, started just prescribing these meds. Oh, you'll get better. Well, people did get better, but medications help from this point forward. What medications don't do is help address all the behaviors, all the life issues, everything else that kept you alive until this point. I used to call them maladaptive coping mechanisms, but if somebody's still alive, it's not maladaptive, right? But when people have serious mental illness, especially depression and things like that, they need to look at what are the patterns that they've established in their life, and they usually aren't the healthiest, right? Same with addiction. Medication first, it helps from this point forward, but it doesn't address all the other things in your life. And this slide is really helpful because it talks about when somebody has an addiction to a substance, there are ripples in the pond with your families, your loved ones, your jobs, your ability to have a secure housing, secure food, all those things. So the agonist therapy is just the beginning. It does more than keep people alive, but it helps your brain work so you can engage in the work you need to do. Okay. Happy people. Okay. Joanne, friendly. I didn't make this slide. That's why I made fun of it. Okay. Recovery support efforts. The other things you need. Third bucket we talked about. So many people we're seeing right now with serious opioid addictions are homeless or housing insecure or living with somebody else or living in a dangerous situation. Part of the reason they enjoy being on the opioid state target response team is my glamorous career in correctional healthcare and homeless healthcare. But I took care of a lot of people, especially women who were in really tough situations, drug use, prostitution, so you can take drugs, so you can do the prostitution and all that stuff. Happens to men too, but it really is the story of a lot of women in recovery. But we need to provide a place where people can recover. That often means taking them out, helping them, I don't want to say taking them out of a toxic situation, helping them out of a toxic situation. So with STR funding, some of the funding goes to helping people set up recovery houses that meet a certain accreditation level of quality. And I'm involved with some of that through my work at ARCA, which is really exciting. We're using more peer support specialists, people who have been through addiction, who we can work with and help train up on basic psychosocial therapy. They've already been through the process so that they work with folks and basically walk with them through early phases of recovery. You talk a good economic argument that I talk to a lot of people is these folks have a wealth of experience and empathy and are inexpensive. It's not like hiring a physician or a PA or a licensed clinical social worker, but these folks can really walk the walk and talk the talk with people in recovery. We also have some recovery centers. We have one in downtown St. Louis. We have a second one opening soon. And then checkups. How do we keep people engaged in treatment? It doesn't do a whole lot of good if we have somebody for a month, then they relapse and we lose them. So how do we keep engaging folks in treatment? One example of a technique we're using at ARCA downtown, which is down at 14th and Olive, where I'll be heading back to today after this. We do something called contingency management. That's the technical term. It's a therapy that works really well for people with serious mental illness and people with addiction. What that looks like at ARCA is people now can come in for their appointment, which can take a while because they see a case manager, they see a prescribing provider, and they see a nurse. But they come in and they can get a breakfast wrap or a lunch wrap. We feed them breakfast or lunch, free. You might think, that sounds like bribing. Okay, let's get back to Maslow's hierarchy, right? For us, it would be bribing. Pizza, okay? But what this does is when you're in survival mode, having food really helps. It's a driver. We have already seen people are coming early, or I should say on time for their appointments. They're staying for their whole appointments. They're picking up their meds as a result because we're providing a wrap, a piece of fruit, and a bottle of water, okay? So those are those things where we're working on this. Another link there. Again, primary goal in policy changes. We want to be able to inform Missouri that they need to change how they fund addiction services in the state. Dirty little secret time. Okay. What the state has done traditionally, they funded group therapy. You get 10 to 12 people together in a group. They talk about their addiction. There's a good place for group therapy. My thing, though, is that it's usually the underlying cause of addiction, like people who have experienced trauma, people who are refugees, people who have co-occurring disorders. Group works better for that. But what some providers did in the mental health system was, ooh, I can get $67 an hour if I plug somebody into group therapy. Guess what they did? Not all of them, but many of them. Oh, we'll run groups all day long. 10 to 12 people, $67 an hour. $67 times 10 is $670. We'll do 8 hours of this, and then we can do 8 times that. So $5,600 a day. And we'll plug in a movie. There's your group therapy. Not real efficacious, folks. Okay. So what we want to do on our team is to show if we can get folks in front of a prescribing provider, if we can provide one-on-one therapy, peer support services, people are getting better. Okay. Now, if I get a nasty call from the Department of Mental Health today, I know somebody in your squeal, so I don't hear it. But that gives you an example of the real practical outcomes that we're looking for with this work. Okay. And we talked a bit about this as well. What can you do? And this is where we'll finish today. I have a few other slides here on Narcan, including links for videos if you want to learn a little bit about that. But we'll end with this slide today. What can you do related to treatment? Remember, people who have addictions are people first. No one aspires to become an addiction. Obviously, I was at my best. Putting the slide together. I have a bad habit of pouring the drink and looking at PowerPoints on the weekend, so that must have been it. Okay, remember, people who have addictions are people first. Okay. 2, use respectful language when speaking about people with addiction. Everybody here has probably heard about person first language. A good example I use is nobody who's bringing their elderly parent into the ER wants to hear some medical student say, the broken hips in room 6. Okay. It doesn't hurt a whole lot to put the person with first. Okay. That's what people first language is. Educate yourself on the different treatments. You will be amazed when you're out doing clinical work how many people my age and older will say, I don't believe in methadone. My response would be, as our Buddhist friends tell us, it doesn't matter what you believe. What is what matters. You'll get some weird messages. Remember, follow the science. And support people who are finding success with medication who are in addiction. Every chronic disease state in the United States, we expect people to have bad days. I often say, if you know somebody with diabetes and they have a high reading on their glucometer, I don't know anyone who says, well, you're obviously not concerned about your diabetes management, so I'm taking away your insulin. Okay. We do this to people with addiction. You obviously are not engaged because you use today. Guess what? Primary chronic relapsing condition. Things happen. We need to show compassion. We need to follow the evidence to do it. So here's stuff you can look at on your own because you will get all this. Cool little video if you click on this, what a Narcan reversal looks like. We can have people come in and do that. And there's stuff here. Here are your resources, the folks we talked about today, all right here. And I wanted to leave time for questions. And like every St. Louis U classroom, the clocks don't end. They're not synchronized. We haven't gotten there yet.
Yeah, so we have 10 minutes for questions, and I would just like to ask anybody that's remote to type your question into the chat box, and I can help you moderate. I just think that might be easier so we don't have sound issues. And then for anybody here, obviously, just ask your question.
Yes.
So when we're looking at view, would it be possible to create a couple different variations of different doses at different effects that could cater to a larger patient?
Right, our question was, if you look at Butte, can we do different doses for different purposes? And the answer is yes. The interesting thing, even when we start off buprenorphine, it used to be that you started everybody off at 4 milligrams. Then it said, we'll start off everybody at 8. But what we've done now, we mean in general, what the field does is work with folks, because we have opioid withdrawal scales, but we also have craving scales. We work with folks to focus on symptom management rather than an absolute dose. So we do have multiple doses for that reason. And then in time with buprenorphine too, we would expect in time as the brain heals, we would want to titrate that down with our patient to the lowest effective dose, right? So that's a good question.
I thought of a question, Dr. Rapp.
Oh, yes.
So my question is, just because of the fact that a lot of this epidemic kind of has its roots in pharmaceutical companies, and then physicians kind of being led to believe that it was safe to prescribe some of these drugs. Is there a sort of a backlash in the community or among the addiction community or anybody trying to deal with treatment in communities, saying, you know, it's hard to trust medication-assisted therapy even when we see the science, because we thought we were seeing the science of these pain management meds?
Mhm.
And if so, what's the state targeted, like how do you work with that in the
Okay.
community?
Yes. Okay.
That's a loaded question.
It's like a Terry Gross fresh air question. All right. I'm doing a talk in a couple months at a public health conference in Columbia, and they actually took the title that I have, and it's a joke. What the hell was my doctor thinking? Because if we go back decades, we look at why did we not see this coming? How did we all get duped with this, right? When I was a third-year medical student here, when I got out of these students, and I was on surgical rotations, we were on paper then for charting, paper. We didn't have EHRs. So our job as a medical student was to write every surgery in the book. Percocet, 1 to 2, Q4 to 6 PRN pain, 162 refills. And we were told, if you're in pain, you don't get addicted. Okay? I think we have much more skepticism now, which is a good thing, and much more transparency. The good thing about these meds is that we have seen these meds have been used for decades, and especially in Europe, in Western Europe, and we have a lot of good outcome data to show how these meds work. And we also have decades of brain chemistry to show how certain areas of the brain light up with dopamine, don't light up. We see how the brain heals. So we're being much more transparent. And also back in the day, like when I was in training, we did not have the transparency that we have in medical trials as we do today. We've done a lot better with IRBs, with education, and with having to report negative outcomes in studies. And we're also much more skeptical of studies that are only sponsored by pharmaceutical companies. Yeah. So we have to overcome that bias in the community, and people have to learn to listen again and to do primary research. You probably all wonder, why do I have to learn how to read an article? Because you really do want to be able to do some of your own research to verify what you're being taught. Other questions? Yeah.
The recovery housing, is that contingent on participation in a program and or sobriety?
Recovery housing, is that contingent on participating in a program or sobriety? What would you guess?
My guess would be it is.
Traditionally, it has been, right, and that's part of the problem. Traditionally, recovery housing has been called dry housing. You have to be sober, you have to be off substances, and you have to be participating in a 12-step program. 12-step programs have their place, but if 12-step programs worked as beautifully as people who have found sobriety in 12-step programs will tell you, we no longer have a problem with addiction. They work well for some people. What are the recovery house program that we have now with my folks at ARCA, but also the ones that get funded now? Sobriety is expected, but it is not absolute. People who run the programs expect you're gonna have bad days. You're gonna have a positive drug screen. You're gonna relapse. And also, we don't tie those services to, you have to do this many meetings a week. They're strongly encouraged. All of our programs in Recovery House, for example, are all peer-run programs. We have no paid staff. The people who run the houses get free rent. So it's a sober fraternity is what my buddy Sunil says. I know, not oxymoron right there. But yeah, we have to change our model so that our housing models reflect science and reflect the disease state. Yes.
Do you know what it looks like in Missouri for a physician assistant to be eligible to use MAT?
Yes, I do know.
Would you share, please?
There's 24 hours of training, which feel free to email me and I can share that with you. PAs and NPs have to do 24 hours of training. Physicians have to do 8. That's because physicians are so much smarter. No, it's because the AMA stuck their toe in it. Okay. But on December 12th of this year, we're going to have our second annual Addiction Medicine Day, where I'm going to do the 4 hours live of that. And then residents and practicing physicians can do the other 8. And PAs and NPs can do an additional 20 online. Then you take a test, which is like ridiculously easy, and you're able to prescribe. One of the cool things that came out of our work in terms of policy work was now in Missouri, we took off this limit of 5 days only of prescribing that a PA or NP could do with bupe. Now you can write for a whole 30 days if you have the waiver training. So that was something we were able to really focus on. So yeah, that's something that I do that kind of training regularly as well. So you can do that here. Question?
I feel like as students, a lot of our lecturers have told us essentially we need to just not prescribe opioids like at all, like because of this opioid crisis. Does pulling back like that really help a lot with the addiction, or is it more from like outside sources, like you said, China or different countries that it's coming in? Like, does that actually have an effect? Us being like, well, we're going to just stop doing it.
Well, do you think it's good patient care? No, good, thank you. Question was, what about people who are completely pulling back from opioid care? I call them losers, okay? It's called educate yourself, people. Some people need opioids, but there's a big emphasis in work, and there's a couple of people in the room here I'm working with from SSM, where we're looking at how do we promote responsible prescribing, evidence-based prescribing, so that we have tiers of approaches. When you get crazy answers like that, talk to your friends who are PharmD faculty, or who taught me responsible prescribing. Extremely important. We need to keep these tools in our tool belt. When Percocet was delivered, OxyContin was delivered initially or presented as an option, it was never intended for chronic use. It was meant for short-term post-surgical pain, but then it got marketed for chronic use. So you got a very good point there. You don't want to go to the opposite extreme and not take care of your patient because you're scared, okay? You need to educate yourself on how to do this stuff correctly. And that's part of the work that I'm doing and why I want to get an addiction fellowship started here so we can create some of those conversations. Do we have one more? Yeah, one more.
So what impacts do you see on pregnant women and then the babies of women who were addicted to methadone and then the delivered babies? So going forward, like what can we do about it?
Okay, let's talk about perinatal care in 30 seconds. No, good question. We have a center here called the Live Center at St. Mary's Health Center run by Dr. Jay Shakin. Rock and roll. She's helping you start the fellowship. Her whole career is taking care of moms and babies. She's a maternal fetal medicine specialist with addictions. And of course, most of her program now is women on opioids. We know with increasing certainty that it is best to keep moms on agonist therapy during pregnancy. The standard of care now, if it works, if the cravings are controlled, is bupe, because it reduces the risk of other side effects, infections, withdrawal states, other substance use, with cravings under control. And then the very cool thing at the Wish Center that they found out in the model of care they deliver there is that, guess what the best way to help detox a baby born on opioids is? More time with mom. So they do an in-rooming program where the baby spends time with mom. not so much time in an ICU or PICU, or NICU, I should say. And they have a monitoring program there so that the mom knows what to watch for with the baby as well. So yes, by and large, if mom has an addiction to opioids, mom does better and baby does better on maintenance agonist therapy through pregnancy. But as you can imagine, if it's hard to find providers doing this kind of work, it's incredibly hard to find providers who will take care of pregnant women. So that's a lot of our work at ARCA now, is training up our folks, especially our NPs we have with prior experience, how do we work with OBs and family docs to co-manage patients with opioid use disorder. We will stop there because I'm sure you guys have mostly something else to do today, or you're going to go get a margarita. But thank you all for coming today. You guys want to know more of this? You know where I live. You know my email. Let's create a cultural change here where this becomes part of our normal course of training. So thank you.
I also just wanted to say that for the people who are in the room today, we will send the slides. And then can we send those STR cards about all the drop-in centers for Narcan and treatment statewide?
They're all on this. They're all on this state. They're all on the website. The newest one. So that's the best place to go.
Okay.
And we'll email out these slides to other people too.
Yes.
Everyone remotely.
They've got that.
Oh,
they've got
already
them.
got it?
I was
Cool.
afraid. I wanted everybody to show up here that said they were going to show up, so I didn't email you guys the slides.
Good thing she's not faculty.
So thank you all, and thank you, Dr. Rottnek. We really appreciate it.
If there's pizza left over, take some for later. Yeah. Yeah. Exactly. Yeah. I know. That's why.
Oh, thank you. It comes from Anna. I can't write it all together.
We know the week.
The last people who are making these rules are people who know nothing about that. And if we don't step up,
There will be a recording. So I'll send out, oh, that's another thing I forgot to say. I will also,
I turned it off, like the number needed to treat is 300.
I will also send you guys out the live audio recording.